Hi, everyone. Thank you so much for joining. We're going to give it just another minute to allow for others to log in, and then we'll get started. Thank you. Welcome, everyone, to the 2021 Virtual SMA Conference. This is Jessica from Cure SMA's Family Support Department, and we thank you all so much for joining us today for the Reproductive Option for SMA Family session. We are so grateful to our national presenting sponsors, Biogen, Genentech, and Novartis Gene Therapies for their incredible support of this year's Virtual SMA Conference. Please note that all lines are muted during this session other than for the speakers. And if you do have any questions, you'll find the chat conversation tab, and that's located on the right-hand side of your screen. You can submit questions throughout the session using that feature, and then we'll answer as many of these as we can at the end with our Q&A portion. And now we'd like to introduce our speaker, Dr. Stern, with Genetics and IVF Institute. Take it away, Harvey. Thank you so much.
Thank you so much, and welcome to everyone. And this workshop usually is about 3 hours long. We talk about the genetics of SMA, we talk about counseling issues and testing issues, and we talk about reproductive options. I'm not going to be able to put all of that into one 40-minute session. We're going to go quickly through some of the things, and then again, if there's specific questions, I'll be able to answer them after we finish the slides. And for this session, we're going to concentrate on the reproductive options. However, SMA, as we're all aware, is a recessive disorder. That means each person has 2 copies of the gene. If they pass on an abnormal copy, each parent, the child, will have no normal copies of the gene and will be affected. Now, the molecular basis of SMA involves the so-called survival motor neuron gene, and this is on chromosome 5. It makes a protein that maintains the motor neurons that enable movement. Now, normally, genes are composed of 2 parts, the part that has the information, and these are called exons, and then the intermediate parts are called introns. After these are made, the intermediate parts are stripped out, and the mature protein is made. Now, there is, in addition to the normal SMN1 gene, a pseudogene called SMN2. It is similar, except it carries a genetic change that causes the loss of one of the coding areas. On this, it is coding number 7 here, and this drops out because of the genetic change and produces a non-functional protein that has only about 10% of the normal SMN activity. Now, the genetics and the testing of this is something one can work through, and either one will find out by carrier screening that you are at risk, or because of a family history. So, as Jessica said, we want to thank our sponsors, but the other thing is that these people are making a huge difference in the SMA community now. If you've been going to these seminars for several years, it's pretty amazing to see the changes and the improvements, and hopefully the continued growth in therapeutic options for SMA. For those people, though, who are considering families right now, there still is a very difficult pathway ahead because the questions are still there, difficult decisions about family building. Now, before we talk about them, of course, decisions regarding childbearing are certainly personal and reflect people's own religious and moral views. This is not a one-size-fits-all type of issue and should not be expected to be. And couples who are at risk should be allowed to really make up their own minds. And it is the role of healthcare providers to show all the options, talk about the pluses and minuses, and help people make decisions. Now, of course, naturally, one's decisions are going to be influenced by your experience with SMA. Those people who've had a child or a close family member affected are going to have a much different appreciation of SMA and experience than couples who are identified by carrier screening but have no clinical experience with SMA. Also, of course, there are a number of decisions involved in treatment modalities, and these are influenced by people's views about prenatal diagnosis and IVF and assisted reproduction. And people call this the playing God factor, that you're messing around with something that shouldn't be. And again, these are all part of personal decisions. So what are the reproductive options then? What is the outcome? First of all, the most common outcome is the one listed as number one, which means that people have no or no more children. They limit their family size. And this is a choice that's made because people feel uncomfortable with the other options, and it's certainly one's privilege. The next two, number 2 and 3, are certainly treatment options that can get around the risk factor of SMA. There are plenty of children in the world who need adoption. And a gamete donor who is tested for SMA can certainly alleviate the risk. The problem with these two is what I always tell people is that having children is the ultimate act of narcissism. And when we have them, we want them to look like us because we think we're pretty cool. And there's good things that we want to pass down to our children. So I think in most cases, if it's a situation of adoption or gamete donor or no family, people will consider that. Otherwise, no. I think people would be much happier to have children with their own genes. Now, one can, of course, conceive naturally and either do nothing, which most people, I think, would not choose, or would do some kind of prenatal testing on an ongoing pregnancy. And that's certainly a viable alternative. It's been around for a long time. Because of the nature of the recessive inheritance, 3/4 of the time, the conception will not be affected with SMA. The problem is, of course, it's the other one that gets in the way. And one of the downsides of this approach is that you're doing what we call a trial with an N of 1. There's only one shot in there. There's one baby in the uterus. It's either going to be normal or it's not. And, for some people, those odds are not good enough. Also, for some people, the alternatives are not something that they wish to have to deal with. For some, termination for religious reasons is not going to happen, or some people feel that that's not something that they feel comfortable with. And this is where pre-implantation genetic diagnosis, or PGD as we'll call it, comes into play, because it allows one to sort of change the rules, to cheat, if you will. Instead of having a trial with an N of 1, one can create multiple embryos in IVF to test, and you're more likely to then find an embryo that is a good quality, healthy embryo that is not affected with SMA. Now, PGD involves the use of assisted reproduction to provide a method of prenatal diagnosis of embryos as opposed to fetuses in utero. And it does offer as I said, an alternative to the traditional methods of prenatal diagnosis, including CBS and amniocentesis. Now, this is not a new technique. It's actually been around since 1990. So we're in our 31st year of PGD. And since then, about 800,000 cases have been performed worldwide, with over 350,000 children born after this procedure. Basically, what PGT here, PG'T-M, is the new terminology. It stands for pre-implantation genetic testing for a monogenetic disorder. This was not meant to make it simple for anybody. I think the terminology is very confusing, but it is what it is now. So M stands for genetic disease, monogenetic disease. So in this case, one would create normal embryos, and one can test those embryos just like one can test a fetus by taking some of the genetic material from the embryo and determine whether the embryo is affected or unaffected with SMA. And you can also test at the same time whether the embryo has normal chromosomes. And these are the two things that you want. You want a healthy embryo, meaning one that has normal chromosomes and is destined to make a baby, because if you don't use normal chromosomes, you're destined to make a miscarriage, which is not going to be very helpful. And also is free of SMA. So as the cartoon here shows, you identify those embryos that have the desired traits, and then you preferentially are able to replace those in the embryo. And at that point, you know, if a pregnancy results from that, that the child will very, very, very likely be unaffected. Now, IVF, this is a whole new world for many people because they've never thought about it before. But first of all, why in this setting do you need IVF? Because this has nothing to do with fertility. The reason IVF is used in PGD is to make numbers, is to make more than one embryo at a time. Instead of a trial with an N of 1, you can have a trial with an N of 15. And which one is more likely to be successful? If you have 15 chances, it's definitely more likely to be successful. So again, it's nothing to do with fertility. And therefore, people who do this have no experience with IVF and really need, you know, to be able to sit down and talk about this and think about it, because they haven't been like the infertility folks who know everything about it because they've been obsessed with it for years. So again, IVF is used to increase the odds of producing a healthy child. Now, PGD does not involve changing the genes of the embryo. This is not genetic engineering. These are the same type of embryos that a couple would make if they had a natural conception. We're just making more of them. As I said, it's numbers. If you make more, you're more likely to find quality embryos that will be free of SMA. Now, the IVF procedure here involves a number of steps. And again, I'm not going to make you an expert in one afternoon at this, but I'll try and just sort of give you an overview, breakdown, why things are done and how things are done. Because, you know, at least I think it's good to be able to let people know, you know, what you're looking at when you consider this type of treatment. Now, a lot of it has to do with the normal menstrual cycle in women. And of course, the menstrual cycle is designed to do one egg at a time. You know, occasionally there's two, but most of the time, the human body is designed for one child use and is not designed to have a litter, which is what we're trying to sort of force to happen. So the components of the IVF cycle involve those listed here. The first step is to essentially try and fool your own, a woman's own body into thinking she's like 5 years old again. We're down regulating, we're turning off the normal menstrual cycle of the woman. The reason we have to do this is if we try to make multiple eggs and hyperstimulate the ovaries, the body would sort of freak out and would try to ovulate right away and would, blow the whole thing. So what we're doing is turning off the woman's natural menstrual cycle and then controlling it pharmacologically ourselves. The second step is a stimulatory step. Just like in the normal situation, a hormone called follicle stimulating hormone, or FSH, is given to induce not just one, but multiple embryos, multiple eggs, from both sides, both ovaries. This process varies in terms of how long it takes, depends on the age of the woman and other factors. Can be anywhere from about 6 or 7 to 16 days. As we monitor the growth of the follicles, which contain the eggs, we'll reach a point where they are likely to be mature when they have a diameter, the follicles, of 20 millimeters. And at that point, we will move towards what's called the egg retrieval. As opposed to natural ovulation, we are going to remove the eggs from the ovary. And I'll show you some pictures of that in a minute. We're going to take them out and bring them into the laboratory where they'll be fertilized in the laboratory. We use a process called ICSI, or Intracytoplasmie Sperm Injection, to fertilize the embryos when we do PGD. That is because extra sperm would stick on the outside of the egg and could cause a false negative result on the testing because of taking daddy's DNA instead of the fetus's DNA in the analysis. Now, we will typically grow our embryos for up to 5 or 6 days, and to see if they will get to the stage of the so-called blastocyst. It's the advanced stage of the embryo just before it implants in the uterus. We will then biopsy embryos that are created and then put them in the freezer. We will test those embryos or parts of those embryos for both the SMA gene and the chromosomes. And then eventually the goal is to be able to return to the womb embryos that are found to be free of chromosome abnormalities and also free of SMA. Now, the timeline of this is approximately shown here. It usually takes a week or so if you do sort of the classical type of downregulation. Some can be faster. The ovarian stimulation, I told you, takes anywhere from a week to 16 days. After that, there is an egg retrieval when the eggs have grown to the proper size. The eggs are then fertilized in the laboratory and kept there for 5 or 6 days. When we transfer back to the uterus, what we'll first do is stimulate the support, what we call luteal phase support. That's preparing the uterus to receive an embryo, and then monitoring for successful implantation. All right, so the early embryo, first of all, fertilization typically in a normal normal pregnancy occurs pretty much around the area of the ovary. And then the new embryo starts to divide and grow. In the 5 days it takes it to go down the fallopian tube. So it is going down and creating more cells. The cells are dividing, so you go from a single cell to 2 cells to 4 cells to 8 cells, and so on. These are the more mature stages, the blastocyst, which has a blastocele cavity, has the inner cell mass here, which becomes the fetus, and the cells here become the trophectoderm, or the membranes of the, and they all have the same chromosomal content. So this is about a 5-day period after the fertilization. So this all is carried out in the laboratory. And after this stage here, one has to either put the uterus back in the embryo back in the uterus, or has to freeze it. And usually in this case, we freeze the embryos to get the results of the testing. We're then able to then identify which embryos give you the highest chance for success. All right, so the main difference between natural fertilization is that the embryo is fertilized in the laboratory and grows for 5 days, where a normally fertilized embryo floats down the fallopian tube for 5 days. But they both end up in the same place eventually here in the uterine lining for development. This is what a stimulated ovary looks like on an ultrasound after the stimulation period. Every one of these is a follicle, which is a fluid-containing space that has an egg in there. So this is one ovary, and then there's one on the other side. So you can see you can get quite a number of little eggs out of these ovaries when they're stimulated. Now, how do we do the retrieval? This is done with a vaginal ultrasound. And having a needle on the top like a bayonet, and this is put through the wall of the vagina once on each side and goes into those follicles and withdraws the fluid and the eggs. And they're given to the embryologist, who counts them and looks at their quality. When you do egg aspiration, the ovaries are extremely large. And this is kind of what it really looks like. You have this big old ovary here. These are follicles. This is an egg in there. So you're essentially pushing through the vagina once on each side and pushing up to this big ovary here, pulling out all the fluid out of there. This is an egg that is ready for fertilization. Now, how do we know? It's usually about 4 hours after the egg is retrieved, but you can tell that it has extruded the polar body. And this tells you that it is ready for fertilization. And this is the process here that is used to fertilize, the ICSI process, Intracytoplasmie Sperm Injection. So normally what happens, is that thousands of sperm come around an egg, one gets in and slams the door, and the others just sit there and can't get in. Now the problem is we're going to come back and biopsy this embryo, and we don't really want sperm on the stuck on the outside, because if you pull that in, you can get the wrong diagnosis, because you're no longer testing the embryo's DNA, you're testing the sperm's DNA. So the answer was to take a single sperm, and they put it in this needle, and then they put that right in the nucleus of the egg and inject the sperm into it. So the sperm is here in a little dot. So this is how all eggs are fertilized when we do pre-implantation genetic testing. Again, it's not because there's any problem with the sperm, it's because we don't want the sperm contaminated, the egg contaminated with all sperm. So again, we'll see embryos go 2 cells, 4 cells, 8 cells, so as they're dividing, the number of cells is increasing. This stage here is called a morula, or a ball of grapes. It looks more like mush to me, but anyway, this is the stage before the blastocyst stage. And what happens then is a lake sort of forms in the middle of the embryo and separates it into 2 types of cells. This over here is called the inner cell mass. That will make a fetus. This is called the trophectoderm. It makes the membranes and the placenta. Now, the fetus and the membranes and the placenta, because they come originally from the same early embryonic cells, should most of the time be exactly the same and be representative of the DNA status of the entire embryo. Now, when we go on and do the biopsy, this part here will start to herniate out. And that's when we will go and do the biopsy. And let's see if this can work. I'm not sure. No, not working. So I'm going to go on. Usually we can get a result in about 2 weeks and figure out which embryos are normal, which ones are not. And then we will transfer it back into the uterus at the appropriate time. And we will, do the same thing, stimulate the ovaries, the lining of the uterus a little bit. So that's the way the thing will work. The analysis we do involves whole genome amplification. And that's how we can take 5 cells and do all this genetic testing, that we can make copies and copies of the whole DNA from the cell first. And then we will do 2 things when we do PGD. We actually test for the direct mutation, meaning that, if one of the letters has changed in the gene, we will test for that. And we will also test the areas around the gene to develop what we call a haplotype. It's like taking out a chunk of a block of houses, that the houses stay next to each other. So what we're looking for is this a stable event, and did it move anywhere else, still on the same chromosome that we thought. Again, with the microarray, we can also test for any chromosome abnormalities, because these can occur spontaneously and can lead to failed implantation or recurrent pregnancy loss. Now, how accurate is this PGD in terms of being able to detect the SMA status and the chromosomal status of the embryo? Well, what I always say is, death and taxes are pretty close to 100%. They're 99, 98. Everything else is lower than that. So we say here this is about 98 to 99% accurate. Contamination with external DNA, not only just from the sperm, as I was talking about, but if you get dandruff from the laboratory clinician in there, in the tube, it will contaminate it and show up. So usually the analyses in this case is done with the surgical clothing and biohazard hood to prevent airborne contamination. Discomfort. The big thing about IVF, the medicines are given by injection. This used to be a big needle that went in deep into the muscle years ago. It's now a subcutaneous needle, like an insulin needle, that doesn't have to go, be so deep in the arch and go so deep in the body. These are much easier. Many women will feel abdominal distension and discomfort during the stimulatory phase, because the belly blows up. The egg retrieval, by the way, is done under anesthesia. So, you're not really the woman at least is not really together during that time. If you shake somebody and you talk to them, they'll answer. But then they'll fall right back asleep again. The complications of this, the main complication was always ovarian hyperstimulation syndrome. But we haven't seen that now in several years since we've been doing these frozen transfers, where, you wait a month and then you come back and get the implantation completed at that point. So ovarian hyperstimulation is not really seen very much anymore. So really, a little discomfort is the major complication. Now, is it safe? Is it safe for babies? Is it safe for mother? And these have been looked at, and over the last year, papers have come out and talked about the safety of this, how it is essentially extremely safe. What does it feel like? Well, with IVF, I'd say most women say that their belly feels bloated. And, in terms of cancer risk and everything, this is not hormone replacement therapy where you're on hormones 100% of the time, every day. This is a temporary thing, for 12, 15 days. So does it really increase the cancer risk so much? I don't really think so. But it's something we're always concerned about, so it's monitored. Now, other questions? So far, have these children been normal? The answer is yes. So far, there doesn't seem to be any increase in the number of birth defects. And as far as we can tell, for kids who are now through the teenage years, that they're normal. Costs, this of course depends on the insurer and the case you can make. In situations where there's a genetic disorder in the family, most people will not just ignore that or want to deal with it. But one has to assume that insurance companies may or may not want to assist you in this, and that the cost is somewhere around $20,000 for a first cycle, and it's a lot of money. So it's not something you just want to do, wantonly. Insurance, I think very rarely they'll help. Depends on the policy to begin with, and whether you have fertility benefits, but we always take the view that we can always ask, and if they pay anything at all, it's that much less that the couple will have to pay. So we make every effort to, petition insurance, but, they're not very nice, and they can do whatever they want. So, it's not been extremely successful. All right, what's the chance of having a successful pregnancy? And it varies depending on a couple of things, such as what kind of testing you had. But, we have found that if the chromosomes are now normal, which means you do concurrent testing for chromosome abnormalities, we're finding that 60% or so CVS pregnancies are normal and ongoing. So we do think that this is a safe procedure. We've not seen, kids come out monstered up or mistakes made because of similarities between gene sequences and so on. And it seems to work for recessive conditions, particularly, and X-linked conditions. You even had people come in, want to know if they should have a boy or just have girls because they carry an X-linked condition. And it depends on someone's views. So I want to thank you all for listening right now. And I guess if we have questions in the chat, we can start. And I'm happy to hang around as long as they let me stay on here and answer your questions if there's anything.
That's great. Thank you so much, Dr. Stern. We really appreciate your presentation today and for being here and sharing all that. We do have quite a few questions that have come through the chat, so we'll just jump right into the Q&A portion and get started. So Dr. Stern, our first question is, do all affected reproducing females with SMA produce eggs that carry the genetic defect?
Do all produce a egg with a genetic defect?
Do all affected reproducing females with SMA
Yes.
produce eggs that carry the genetic defect?
Yes. In that case, there would be 2 eggs, and both would carry, I mean, you know, both genes would be affected. So all the eggs would have 2 SMA type genes. So even though they only pass on one, it'll definitely be affected.
Great. Thank you so much for answering that. All right. Moving on. Our next question is, if the partner of someone with SMA is not a carrier of the SMA gene, then it's not possible for the child to have SMA. Is that correct?
Well, no. One of the tricks in what you see in SMA is a situation where someone can have 2 copies of the gene and look like they're a non-carrier, but the 2 copies can be on the same chromosome. So they are, in fact, a carrier because they have 1 chromosome that has no normal copies of the gene and one that has 2. So if they pass down the one that has no copies on it, then that's a mutation. And if they're having a child with someone else who is a known carrier, then one would anticipate that 50% of those children would be affected.
Great.
There is a
Thank you so
way
much.
to test for that. It's called the 2+0. There's a statistical analysis that's done. And one can test for it by looking for a particular genetic change in the SNP, single nucleotide polymorphism. So most SMA reports now will have that information in there about the SNPs for the SMN1 gene.
Thank you so much, Dr. Stern. All right. Our next question is, are there any risks to testing the embryo so early?
Very surprising now. In terms of the embryo's progression, implantation, and growth, originally when we did PGD, we tested the embryos on the 3rd day. And we did find that removing cells at that stage did decrease the implantation potential of the embryo. And that's one of the reasons why the newer technology involves a biopsy of the trophectoderm on the 5th day. And the advantages there are that you can take out more cells. We usually take out between 5 and 8. There are about 300 cells in an embryo at that stage, where, you know, on day 3 there's 8 cells. So you can see proportionally you're removing a lot lower percentage of the cells. And so also with that, you will get a better DNA signal because you have more than one cell present. You know, as far as damage to the embryo, the trophectoderm biopsy, the day 5 biopsy, does not seem to show any decreased implantation or any detrimental effects. Now, like I said, this is, as a PGD has been around for 30 years, 31 years now. And typically every year there are follow-up studies that are done to see if there's anything particular about children who've undergone this treatment in terms of their development and health and so on. And quite frankly, at this point, there does not seem to be any particular repetitive pattern of any kind of problem or malformation. So in the end, I would answer the question by saying there does not appear to be any detrimental effect to the potential child.
Thank you so much for taking the time to answer that one. Right. So that question actually had a two-part to it. So the second part of that question is, what are the chances the re-implanted embryos survive the same as traditional IVF?
Well, there's two ways to look at this. You can say, well, are you comparing this to see if it inhibits or somehow impacts implantation, or the effect of the PGD? And the ability, one of the main advantages of doing the PGD is when you test the chromosomes, you are better able to identify which embryos have the best chance of resulting in a successful, healthy pregnancy. And that would be an embryo that's free of SMA, no more than one copy, still has a normal SMA1, and has normal chromosomes. So if you identify an embryo that has normal chromosomes and is free of SMA, we find, that embryo has about a 60% implantation rate. Now you can compare that to when we, did IVF without any kind of testing, and the pregnancy rates there were around 25 to 30%, maybe. And because the answer is, even at a young age, a significant percentage of the embryos that someone makes are abnormal. And that's why historically, you saw IVF clinics with a shovel putting in tons of embryos in the past, thinking, well, if we put in a bunch, at least, one or two may stick, and then what did that generate? That generated quads and quints. So the better choice was to pick the higher quality embryo and only put one in because that's really what you want. Right now, I'd say the most common thing we do is transfer a single quality embryo until someone's over 42 or so. Before then, the pregnancy rates are certainly high enough that it's justified.
Great, thank you so much. All right, moving right along. Our next question we have is, you indicated that through PGD, you're able to identify those embryos affected with SMA and
Yes.
also with chromosomal issues. What kind of chromosomal issues can be identified?
When we do the chromosome testing, we test all 23 pairs of chromosomes by a technique called next generation sequencing. So we're sequencing the genes on there. And it will evaluate all chromosomes. The common test that people use now, the NIPT, looks at 3 chromosomes and the sex chromosomes. So this will look at everyone from number 1 to number 23 in the X and Y chromosome present. What's it doing? It's identifying more abnormalities. And now, the 3 chromosomes that are traditionally tested for are 13, 18, and 21, because those 3 can produce the so-called viable pregnancies. And, you know, I think the testing that is done with PGD is far superior to NIPT in terms of the quality. So it really will identify pretty much all chromosome abnormalities.
Thank you so much, Dr. Stern. Appreciate your time answering all these questions, these great questions. Our next one is, can PGD be used to confirm carrier status of embryos?
Yes, it will show the carrier status. But, you know, our main goal in it is to show that there is at least one normal SMN gene. You know, in terms of carrier status, that's probably something that's best confirmed before you do PGD, because if you're not a carrier, there's no point in spending the money to do PGD. So, you know, we test all the people first, just to make sure in our hands we can identify their genes. And then obviously there's an interest in the number of SMN2 copies that are in, because if someone has an embryo that does not have a normal copy of SMN1, you know, if you have 4 or so copies, 3 or 4 or so copies of SMN2, that person can have very little symptomatology. So, you know, there is some interest in determining that, but, you know, really in PGD, and you can determine, you know, whether there's 1 or 2 copies of the normal gene. So you do know if one is a carrier, and you would expect to see it. But like I said, it's not probably the better way to do it. The better way to do it is by direct blood testing.
Thank you very much. All right. Our next question we have that came through is, can the first steps of IVF, DR and OS be used in conjunction with natural fertilization to increase the success rate of conception?
Well, in general, if one is hyperstimulating someone, you want to be very careful about having natural conception during that time, or having intercourse during that time, because there's so many embryos, potentially so many eggs floating around in there, and one could produce a huge number. You know, you can end up with a high order multiple pregnancy. So usually when someone's doing IVF, we recommend not to have intercourse for that reason. Also, you know, it won't be, you know, it'll be different from the other ones, and you can, you know, end up not knowing which one you're testing.
All right. And then all right, our next question is there a chance with egg or sperm being affected depending on the type of SMA that the person has?
Is it possible that the egg or sperm is affected by the type of SMA? Is that the question?
Yes. Yep, exactly.
Not that I'm aware of. You know, obviously the ratio of SMN1 to SMN2 is different. You know, if someone is affected, has an affected pregnancy, you know, occasionally people are interested if there's 3 or more copies of SMN2. because those children would not have the severe neurological issues with the classical SMA. But as a rule, what we're looking for when we're doing PGD is there a normal copy? Okay, we're looking for the unaffected alleles from the parents. So we would know what it is, and you would see the presence of, either you're going to see SMN1 and SMN2, or you won't see any SMN1, and then you know that it's an affected
Thank you so much, Dr. Stern. All right, I think we have time for just one last question here before the session ends. So our last question for you is, if a parent has SMA, is the best case that the child is a carrier?
Yes, because if the parent is affected, that means on chromosome 5, both of the copies carry an SMA mutation. So the child will inherit one or the other from that parent. So.
Great. Thank you so much again, Dr. Stern, for taking the time to answer all these questions, and thank you everyone for submitting these questions. We are going to go ahead and end the session, but feel free to use that chat function throughout the conference. It'll be there, and Dr. Stern is able to answer questions as the conference goes on, or we can send it to him at a later date. So again, thank you, Dr. Stern, and for everyone for submitting your questions and being on today. There is a survey linked in the session page, and you'll also be receiving a follow-up email with that survey link, and we welcome any feedback that you have to share with us. Once again, we are incredibly thankful for the support from our sponsors for making the 2021 Virtual SMA Conference possible. Be sure to join us this evening for the very first virtual exhibit hall, which is from 4 p.m. to 6 p.m. Central Time. You can check out all of the booths, see the products and services that these exhibitors has to offer. And the more booths that you attend, the more chances you are entered to win a prize. And that prize will be announced at our closing session Friday evening. And if there's anything at all that we can do or any additional questions you have, you can always reach us at familysupport@curesma.org. Thank you so much again, everyone, and have a great day. Thank you for joining us for the 2021 Virtual SMA Conference.
Have a great day. Stay safe, everyone.
Thank you, Dr. Stern.
Thank you, Jess.